I'm Kondwani Jambo. I'm a reader at the Liverpool School of Tropical Medicine, but I'm based at the Malawi Liverpool Welcome Program. Welcome to the best session of this 125th. Our first speaker, we'll have 4 speakers, and then we'll have our perennially. So I'll take the first 4, and then Frances will take the last one, which will be Liz Corbett presenting. So the first presenter happens to be my office mate, Augustine Choko. So Augustine is a senior lecturer here at LSTM and the co-lead of the population health at the Malawi Liverpool Welcome Program. He's worked for over a decade on HIV research, and he's among, I think, the gurus on self-testing, whether it's HIV, SARS-CoV-2. I hope one day there'll be TB self-testing as well. So over to you, Augustine.
Thank you very much, Kondwani, and such a pleasure to speak to you soon after lunch. And I'll be giving some sort of reflections, historical reflections on the subject of HIV self-testing, but also looking ahead, what are some of the advances that are coming up. So it's interesting, actually, it's quite so many years ago now, back in 2010, we started looking at the question of whether untrained people can perform their own HIV testing. And I'm showing data here from a trial, very first trial funded by the Welcome that looked at this question. And what you see is uptake of testing on the graph, first month, 6 months, and 12 months. And the x-axis is showing also the age groups. And you can see that the youngsters' uptake was very high, but also the uptake was much higher among men, and we sort of know that it's much harder to engage men than women across all the period of testing. It also demonstrated very high first-timers testing, so up to 44%. And we saw early engagement and also people being diagnosed early, as well as increasing engagement among couples. Reassuringly, we didn't find any major safety concerns despite doing nearly 27,000 episodes of testing. So this was a real catalyst at the time, but also was pretty much in sync with the 1990 UNA's targets at the time, that we are aiming to diagnose 90% of people living with HIV and getting 90% of those onto treatment and 90% of those on treatment virus suppressed. But also what was really impressive was that within the first 6 months, this trial showed a 2-fold increase in people who were taking ART treatment. So subsequently, we went on to do sort of one of the largest, probably in the whole world, evaluation of HIV self-testing through the Self-Testing Africa project back in 2015. And we had very clear, simple 4 goals at the time. The first was to develop a sort of guidelines through WHO that relies on data from the national systems to sort of give those recommendations in terms of whether HIV self-testing could increase or should be included as part of the testing algorithms. The second was also to have national guidelines and algorithms to accommodate HIV self-testing in all countries by the end of the project. And the third was to really catalyze the market in order to allow products around self-testing to enter the market. So this required, as you know, pre-qualification systems by WHO. And finally, we wanted to provide sort of market size and market landscape for HIV self-testing. And we had a very clear aim to actually look at price reduction in the product that was there at the time. And what we saw was this was very transformative, culminating in achieving all the goals by 2017 with the supportive guidelines in place and policies in place at WHO and most national systems. And what I didn't say in the beginning is that when we started off, self-testing for HIV was forbidden in many countries. Only one low-middle-income country, Kenya, had sort of supportive policy. So it was a real achievement to have this really expanding and reception for policies. But also, the work that started and continued formed the basis for pre-qualification systems at WHO that has actually allowed COVID-19 as well as Hep C self-testing products to be pre-qualified globally. And finally, when we started off, the cost of the kit that we are working with, which was an oral kit, was $45 in the US. And by the time SHHHAR was finished, the price came down to $2.5 with a price buy down from the Bill and Melinda Gates Foundation. So as of this month, we now have up to 102 countries that support self-testing and 63 that are actively implementing HIV self-testing, which is quite impressive if we look at it in terms of the number of years that have passed. My own involvement and my own work has been in Blantyre, but also across the region in Africa. And here I'm showing the sort of my first trial, which was offering HIV self-test kits, targeting the male partners, but via a woman who was pregnant and attending antenatal care. What you see on the which is my right panel here is the blue bars are all offering self-testing, and the black is the standard of care, which simply invited the male partner to come and have a test at the clinic. And you can see that testing increased nearly fivefold in that study. And the left panel shows linkage to either treatment or circumcision. And again, you can see that increased with the interventions. Particularly, we added more interventions here, which were based on financial incentives. That increased quite significantly the linkage step. So these data actually were very impressive to the point that the Minister of Health asked us to include sort of a pre-national scale project evaluation in Malawi to look at the question of whether these kits could be offered targeting male partners at antenatal care. And so we did this subsequent trial in randomizing 27 clinics in Malawi. And those results again confirmed the very same results that we've just discussed, showing significant increase in the number of male partners, in the proportion of male partners that were tested, and also increasing significantly the linkage for ART or circumcision. So there are so many ways now that people are building on HIV self-testing success. So I'm just listing all of them here. The first is to optimize the delivery of sort of mechanisms to allow to affect transmission, such as pre-exposure prophylaxis or PEP. And also there are now products that allow dual testing, such as with syphilis and as well as HIV. And we saw that there was COVID-19 self-testing to the point that Kondwani says that I'm a guru, which I'm not. And finally, very exciting, and I'm showing some really impressive data that we've just completed recently, is the idea that we can use self-testing to support integration or combination with other infections, such as HCV. And we've done a recent trial using this to affect demand for schistosomiasis, which is this little lovely trial here, which is called FISH. And it was done in Mangochi, which is a lake district in Malawi, recruiting fishermen there. And the idea was that the arm that provided the self-test kit was compared to just having leaflets given out to both teams to get them to come to a beach clinic, sort of a beach clinic that we mounted within 28 days, and they could access either HIV services or schistosomiasis services. And what this showed was very surprising that when you add HIV self-testing, it decreased the prevalence of schistosomiasis within 28 days. And everyone said, well, how are these related? Because you have high enough participation, more than the other arms that are not providing HIV self-testing, this led to very high engagement in testing as well as taking up presumptive schistosomiasis treatment for the fishermen. And this trial also obviously showed a significant increase in the proportion of fishermen who were tested for HIV within 28 days. So that has been quite exciting. But I suppose the question going forward, or learnings that we could take from this journey, is why was this so successful? I think firstly, the questions were quite novel in the beginning, because at the time, as I said, policymakers as well as researchers weren't really considering this. But also the fact, I think Jeremy was speaking about this this morning, the fact that we had world-leading multidisciplinary team, so epidemiologists, health economists, social scientists coming together really to work on this, to address the question, meant that we're able to provide data on many angles, not just saying, well, this is a trial that's going to increase, but how about suicides? How about people's perspectives? So that was really impressive on that front. But also, as I said in the beginning, Wellcome Trust was very willing to try this and fund it. And so for us, that was really novel and allowed us to build that big multi-country study later on using the united funding. And finally, very strong collaboration between policymakers, researchers, but also implementation partners. So we had the Population Services International as the implementation partner, and us as researchers were able to evaluate some of these having not been involved actively in the implementation itself. So that really, those are sort of the key things that we can take forward for how you can design and think about something that can have such type of high impact globally. Finally, I want to end on two very positive notes. The FISH trial just got this cover page in the Lancet Global Health, which is really good for us. And the second is that the HIV self-testing story is one of the 6 case impact studies that contributed to LSTM being number 2 on the Times Higher Education ranking. So I think it's really, really impressive. So just to end on that note and acknowledging the funders, participants, collaborators, and all the people that have also supported me throughout. Thank you.
So keep your questions. We'll take the questions at the end. I think one thing Augustine has not told you, that he's also a fisherman himself. So our next speaker is Euphemia. And Euphemia is a professor in epidemiology and global health at the LSTM, but is also a deputy director of science at the Center for Sexual Health and HIV/AIDS Research, fondly known as CeSHHAR, in Zimbabwe, where she leads a large portfolio of operations research, collaborating with researchers across LSTM and other UK universities, as well as US universities. She holds an NIH Global Research Professor, one which I aspire to have one, and is a co-editor of the Lancet series in self-care, and is a member of and has chaired several WHO panels. Welcome, Euphemia.
Thank you, Kondwani. Good afternoon, everyone. I'm delighted to have this opportunity to discuss our contribution, the contribution of self-care to HIV prevention. And this is work that has been conducted within CeSHHAR Zimbabwe and in collaboration with various teams. And so to start, I'll tell you a bit about CeSHHAR. So CeSHHAR is a research organization that was founded by Francis Cowan, who is here, and registered as a trust in 2012. And it came off a program of research that had already been operating in country since 1999. Since inception, over 300 publications have been made, and our budget for 2024 is over $15 million. Our vision and mission are as shown on the slide, and they align a lot with those of LSTM. We operate from 3 departments. The Key Populations Department runs the nationally scaled program for key populations, which provides HIV and sexual and reproductive health services to sex workers in their gender diversity, as well as other vulnerable groups. And the first of its kind in Africa, it provides a rich platform for implementation research that has informed global policy and practice. We are also at the forefront of research in climate and health. And at the moment, we have 6 large ongoing research projects on climate and health. And 3 weeks ago, we hosted the inaugural Africa Climate and Health Conference that was attended by over 400 delegates locally and internationally. The Department of Sexual and Reproductive Health and MNCH has also conducted research that has informed global policy and practice, including on prevention of mother-to-child transmission of HIV. And it is the department that collaborated with the highly successful STAR consortium that Augustine was talking about. And from our experience on the STAR research and also subsequent research, we have developed rich insights on how self-care can help drive attainment of elimination targets for HIV. But what is self-care? Self-care means different things to different people, and I've pasted here the WHO definition, where essentially it is when people take care of their health with or without support of a health provider. It includes the 3 components that are shown on the slide. For self-awareness, we are essentially talking about taking care, educating oneself about HIV-related activities or issues. And self-testing would include HIV self-testing as an example that Ogu was just talking about now. And self-management will include things like self-treatment and self-injection. What is really important is that self-care must uphold human rights and other ethical values, while at the same time ensuring that health systems remain accountable. So self-care is not a way for health systems to neglect their roles, but to continue to support people to take care of themselves. And it is highly considered critical by WHO as important for helping us attain our goals for universal health coverage. As you can see from the graph and as well as the table that is shown here, we are way behind in terms of attaining our HIV elimination goals. And there is great acknowledgement that self-care might be important in helping us attain our HIV elimination goals. We are at a crossroads where decisions that are made by political and program leaders will impact whether we do attain our HIV elimination targets by 2030. And we know that uptake of HIV prevention is influenced by how many of those levels that are shown on my right interact with health systems. And I'll talk about how self-care can be empowering. So in this slide, I show my grant portfolio related to self-care since 2015. And today I'll give examples of how we have done some work on combination HIV prevention, particularly talk about the examples of work on treatment as prevention, as well as HIV post-exposure prophylaxis. So starting with treatment as prevention, as part of the STAR consortium that Augustine was talking about, we have conducted 2 community-based cluster randomized trials that have investigated distribution of HIV self-tests at the community level. And in the first trial, we found that community-based distribution of HIV self-tests was associated with an increase in the number of people who were initiating HIV treatment, which we know is associated with a reduction in HIV transmission. In the second trial, we found that communities are very much able and motivated to develop and implement interventions for distributing HIV self-tests. And we found that the communities were then able to target the HIV self-test to individuals who needed them the most. And this has led us to do work among young people, where we've evaluated peer-led models of distribution, which is really important for college or university students, because uptake of HIV and sexual and reproductive health services in this group is quite poor, despite them being, despite the evidence that they are at high risk of HIV. So we conducted a cluster randomized trial in 16 colleges where we compared peer-led distribution of HIV self-tests with collection of self-tests from nearby clinics or pharmacies. And we found that peer-led distribution was associated with higher uptake of HIV self-testing of 30% compared with 20% in the standard of care. Importantly, although the young people we worked with reported high acceptability of the HIV self-test intervention, they also said it was not enough. They reported that they had unmet need for a lot of the services for HIV and sexual and reproductive health, and they requested a broader intervention than just HIV self-testing. So together with the students, we developed a package of services that included HIV self-testing, vouchers for post-exposure prophylaxis and emergency contraception that could be redeemed at nearby clinics or college clinics, as well as condoms, and this was a peer-led intervention. We piloted this intervention at 3 colleges or universities in Zimbabwe, and we evaluated it using different methods, including qualitative methods. And here on this slide, I show the outcomes or the results from the qualitative study, where we find that young people found the intervention highly acceptable. They also acknowledged their risk of HIV and talked about this intervention being very timely because they previously had not had any access. However, we also found there was moral judgment for premarital sex, and this is something that is deeply enshrined in the communities in Zimbabwe. And this manifested in various ways. Sometimes young people found it difficult to go and access services because they did not want to be seen accessing them because of the potential stigma. And also we found there were negative health worker attitudes towards premarital sex, with sometimes health workers being rude to the young people or sometimes denying the services to the young people altogether. But based on the results of the pilot, which were mostly successful, we are doing a wider evaluation of the study as part of my NIH professorship, where due to the global calls for community-led interventions, we are evaluating a package of interventions that include peer-led distribution of HIV self-tests, treatment and prevention, as well as contraception. So in summary, we have found that self-care is something that is really recognized as important for driving attainment of our global targets for HIV elimination. And it's important that health systems continue to be accountable, and that self-care should not be something that that ensures that people are abandoned, but health systems should ensure that they are protected from harms. The research that we've conducted at CeSHHAR among young people and in communities has shown that self-care is highly acceptable and feasible and can actually reach individuals who are previously not reached with services, so can be important for helping us attain our elimination targets. I'll end by acknowledging our funders as well as our participants and our collaborators. Thanks for your attention.
I told you this is the best session. Our next presenter is Loveleen Bansi-Matharu. She's a Principal Research Fellow at the Institute of Global Health at UCL. She's a mathematical modeler. Don't worry. She's using developing the HIV synthesis model. She is a key member of the Bill Melinda Gates Foundation-funded HIV Modeling Consortium, which works closely with WHO and UNAIDS to contribute to global health or global policy decisions on a range of HIV prevention and care considerations. Much of our work has strongly influenced the translation of research into an impact on public health, and all the modeling work is done on the best continent of the land, Africa. Thank you so much.
Thank you. And yes, it is a talk on modelling, and probably too late to leave the room, I'm afraid. But I won't show you any formulae, and I'm not going to show you any Greek letters. So let's start with where we are, the current status of the HIV epidemic in Africa. Well, actually, over the last 20 years, we've come a long way. HIV incidence and prevalence has come down a lot. And that's mainly due to changes in sexual behaviour in the early part of those 20 years, but much thanks to the rollout of antiretroviral therapy in the later parts. But as you can see from this map there, there's still a substantial number of new infections, and it's important to identify prevention interventions which not only lower incidence but are also cost effective. And this is essentially where mathematical models come in. Models now are a critical part of decision making in health policy. We can use models to quantify the risks and benefits of potential interventions. So we can look, for example, at the potential adverse effects of any new intervention, and also the impact on key epidemic characteristics like the HIV prevalence and incidence. We can also look across different time horizons. So if we have a new intervention now, what will be the impact in, say, 5, 20, 50 years' time? And also consider different future scenarios. So if treatment coverage went down with unexpected events like COVID-19, for example, what might be the impact of that intervention? And most importantly, models can be used to assess whether the intervention is cost-effective. So there's many well-established HIV models in the region, actually. I work on the HIV synthesis model, but colleagues also work on the Tanzila-Onze model, which is more than just a HIV model. It's a very impressive, all-disease-encompassing model. And we have close links with all the other modelling groups that you see there. And we're all part of the HIV Modelling Consortium funded by the Gates Foundation. So let me say a little more about the HIV synthesis model. It's an individual-based simulation model. And what that means is that every time the model is run, we generate a simulated population of adults from 1989 onwards, with variables updated every 3 months. So every 3 months, we get something like what you might see in a cohort data set with key variables for each individual, such as their age, their sex, their number of condomless sex partners, whether they've been tested for HIV, circumcision, and so on, for each individual every 3 months. And those are updated. And then for those who do have HIV, we have HIV-specific variables, such as those listed on the slide. Now, for many parameter values, there's uncertainty. So, for example, if someone with HIV stops taking treatment, we are not sure of the probability of them coming back to care. So to incorporate this, we run the model many times, and for each model run, parameter values are sampled using random distributions in order to generate what we call a setting scenario. So what that essentially means is that in one model run, we may have a low probability of that person coming back to care, but in another model run, we will have a high probability of that person coming back to care. And this impacts on the proportion of people on treatment. And those setting scenarios are intended to represent the diversity of characteristics of the epidemics across settings in Africa. Now, the HIV synthesis model has been used extensively by WHO and by country teams to inform policy across the care cascade, but particularly in HIV prevention. So we've done a lot of work on pre-exposure prophylaxis, the different forms of PrEP, the impact of PrEP in a community setting. We've built on the work discussed by Augustine and Euphemia on self-testing. We've done work on the cost-effectiveness of female sex worker programs, and on circumcision. So over the next few slides, I'm just going to go over a couple of those in a little more detail. Let me start with the cost-effectiveness of female sex worker programs. And this work was funded by Wellcome as part of the Amethyst grant, which worked across institutions, but particularly with UCL, CeSHHAR, and Liverpool. So we know the prevalence and incidence of HIV in female sex workers is considerably higher than that in the general population. So any intervention we have for female sex workers is likely to have some sort of knock-on effect for the general population. And we also know that female sex workers have the potential to make a considerable impact on testing and prevention. But what we were unsure of at the time of this analysis is at which maximum cost are such programs cost effective. So using the HIV synthesis model, we looked at low impact programs and high impact programs on the incidence of HIV in sex workers. And these programs differed according to the likelihood of testing, of PrEP, of condom use and STI testing, but also on certain variables for those living with HIV. And what we found was that compared to scenarios with no sex worker program, scenarios with even a low sex worker program had a considerable effect on sex worker incidence, bringing it down, but also had a knock-on effect of HIV incidence in the general population. Now, the table on the right there shows the maximum cost a sex worker program could cost to remain cost effective. And as you can see there, if you look down the table, as HIV incidence in the general public increases, so that's the column on the far left, as we go up in HIV incidence in the general population, the maximum we can pay for a sex worker program to remain cost effective also goes up. So in settings where incidence is less than 0.1 per 100 person years, we can pay a maximum of 7 million per year for a high-impact sex worker program in order for it to be cost-effective. But in settings where incidence is higher, above 1 per 100 person years, we can pay up to over 60 million, and that sex worker program will still be cost-effective. Moving on to voluntary medical male circumcision, again, this was work initially built on a Wellcome Trust grant with Liverpool, but then funded by the Bill and Melinda Gates Foundation. Circumcision reduces the acquisition of HIV by around 60%. And PEPFAR have been funding male circumcisions in the African region for a long while now. But since they first started funding those circumcisions, there's been extensive rollout of antiretroviral therapy treatment. And what that means is that more people living with HIV are on effective treatment and can't pass on HIV. So what PEPFAR wanted to know was that given the scale-up of treatment programs, does the provision of VMMC services for at least the next 5 years continue to represent a cost-effective use of HIV program resources? For this question, we had 5 modelling groups tackle the same question, and those models had different assumptions and different underlying structures, so if we all agreed, that would give that much more confidence to policymakers. So we all modelled the same scenarios, no further circumcision versus circumcision in men aged 15 or over for the next 5 years. We looked at 3 settings, Malawi, South Africa, and Zimbabwe. And what we found was that in Malawi and South Africa, all models agreed that the continuation of circumcision for the next 5 years was not only cost-effective, but actually resulted in cost savings and with health benefits. In Zimbabwe, we had 2 models modelling Zimbabwe. One model found that circumcision resulted in cost savings and health benefits, whilst VMMC was not quite cost-effective according to the other model. And what we also saw was that VMMC, the cost effectiveness of VMMC was dependent on HIV incidence. It was effective in about 2/3 of settings with HIV incidence of less than 0.1 per 100 person years, but in 95% of settings where incidence was higher than 1 per 100 person years. And these results were used by PEPFAR as an evidence base to continue funding VMMC in the region. So a few considerations on getting to 0 new HIV infections. There's still a lot to think about. Are general population interventions likely to be more expensive and more difficult to implement as we get closer to 0? So are targeted interventions, like we saw with that female sex worker program, more likely to be cost effective? There's been work on vaccines for many, many years now, but now we have long-acting injectable PrEP. So we need to know the impact of the vaccine given what we have in terms of PrEP. And although we've been focusing on prevention, diagnosis, treatment and retention is still important. And where are new HIV infections coming from? This is just a snippet of results on that last question, and I won't go into too much detail. So what we try to look at here is, of those transmitting HIV, were they undiagnosed, were they diagnosed but had not yet started treatment, were they on treatment or had they interrupted ART? And what we found was that in 2024, about 70% of those transmitting HIV in Malawi were those who were undiagnosed, And this is just one small part of, again, this is a multi-modelling collaboration looking at different settings. But it does give you an idea of how modelling can help to where those interventions should be targeted. I don't have a summary slide, just a few more considerations. When PrEP first came through, we all thought it was going to be a major breakthrough, and although it did have substantial impact, there's consistently been low retention rates on oral PrEP. So will long-acting PrEP, which is taken every 2 months, will that be any different? Will people come up for their follow-up? Will people come back for their follow-up injections? There's also the introduction of lenacapavir, which is twice yearly and might overshadow existing long-acting PrEP. But we don't yet know much about the cost effectiveness of that and whether it should be targeted to specific people. Could it be used as treatment so people on effective treatment can't pass on HIV? So there's also that question. And finally, as I mentioned on the last slide, there's opportunities to intervene across the care cascade. And so a lot still to consider. I don't have an acknowledgement slide because we work globally, and I was afraid I'd leave someone off. But I did want to thank Andrew Phillips, who first developed the HIV synthesis model from scratch and really has been the backbone of all work since. Thank you.
Another amazing talk. I think the HIV field is doing much better than the TB field. Our next speaker is Dr. Lilian Otiso. He's an executive director at LVCT Health in Kenya, and is also a PhD student in global health at LSTM. He's a health systems researcher and implementer in the areas of HIV, sexual and reproductive health, maternal neonatal child health, gender-based violence, and community health. Over to you, Lilian.
All right, thank you very much, and good afternoon, everyone. Today, I will represent this other side of implementers who take on all that work that you've seen presented and actually take it on and implement it, but also do a bit of research on the side to contribute to more knowledge and the lessons about what we take. And so I work for LVCT Health, which was formerly known as Liverpool VCT Care and Treatment, which was also known as Liverpool Project, among other names. It was founded as a PhD study from a student from LSTM who came back as far back as 1998. And that project was so successful that the government said we must have this registered as an NGO. And thanks, LSTM team seconded Miriam, who came and had it registered. Thanks, Miriam, as an NGO in 2002, and has continued since then as has grown to be one of the largest NGOs in Kenya, implementing a wide range of programs, and actually is the lead PEPFAR implementing partner in the country. And we implement that broad range of programs and have continued to partner with LSTM since then. Actually, if you come to Kenya and say Liverpool, I know LSTM has some projects, but people are actually talking about us. So, all right. So, and now, actually, in terms of growth, we've grown to the point when we were able to get and take over from the larger international NGOs like the PIGO, FHI, and now implement different programs at scale in the country. And we are now one of LSTM's donors with our sub-grants. Okay, so turning to HIV, this is the HIV burden in Kenya. It is one of the countries with the largest HIV burden. I think we are fourth largest. There are about 1.4 million people living with HIV, and people like Loveleen here, we get that data that informs the kind of programs that we do in terms of modeling. And our prevalence has come down to 3.7% from a peak of about close to 14% when the PhD student was doing her study. And I've highlighted Homa Bay, which is the county we're working in, one of the larger counties with a very high burden. But basically what we've seen is that, and we use this modeling data to inform our country priorities every 2 years. We have estimates that inform investments and where they go. And the low burden counties' investments had been reducing, and now we're seeing cases starting to increase in those counties. Moving on to Homa Bay County, which is what I'll talk about today. Even if we're implementing across over 10 counties, actually across most of Kenya. I wanted to focus on Homa Bay as a very good example of doing large-scale program, and it integrates all the different kinds of implementation or interventions for HIV that we have. It's leading and has always been leading in terms of the prevalence, which peaked at 25%, with all the indicators, the maternal, the death rate, and others. But what is unique here is that the drivers of the epidemic are all the at-risk populations. Most of the at-risk populations we have in Kenya are found in Homa Bay. So we have the general population with very strong cultural practices that we saw drove the infection. We have, it's a non-circumcising community. We have fishing community and other activities that really promote HIV infection. So this project is what I'll be talking about, and just highlighting it because of how it's comprehensive, and the populations that are targeted are also broad-ranging. It's in 2 counties, but I'll focus on Homa Bay. And the approach that we've used for programming has been the research policy practice cycle, which is what has really driven the organization since its beginning. And the priority here is to focus on the populations that are at risk and make sure that interventions, whether prevention or treatment, identify or focus on what that population needs. And every ever so often, again, at a national level, at a country level, we look at these are the populations who the infections are increasing, like adolescents and young people at the moment, the key and priority populations, and even men who we've not been finding. And so we do alter and change the program to suit that. We also invest a lot in the health system strengthening component, and that's the whole range from human resources for health to lab systems, commodity supply chain, and providing technical assistance to government to implement the services which are implemented within government facilities or within the community-based organizations. And so that has helped, and we've made sure that there's capacity building, continuous capacity building, and translation of these services and programs from us as the implementer. And we have borrowed from the different research studies done to inform what is done, and then that's taken up by the different implementation avenues. So from what we've been doing over time, these are the results. So you can see how we've now tracked in terms of the new infections have come down. We have the maternal and mother-to-child transmission rates have also come down significantly, although we noted that when we had health systems challenges like health worker strikes, this MTCT rates went up. So those kinds of things about the health system really affect the implementation. And so we keep learning and seeing how do we adapt this, document it. It's a constant process of iteration and learning. And these high burden counties really form a very good basis for how we learn. So coming to the issue of challenges, these, even before the US elections were held, we knew that the PEPFAR funding has been under threat. It was not, did not get reauthorized in the 5-year reauthorization that we're used to, and now it's going year on year. So the reality is that we don't even know if we'll have funding next year. Now we have it's called the Department of Government Efficiency and others. We'll see what that actually means. And so there's a big risk to funding. There's big risks like anti-rights movements. We know we will have to sign the Mexico City policy and others that are coming up. So there are very many disruptions that are coming up, and they pose major challenges in terms of the implementation of the programs. So our priority is to see how do we minimize the reversals. What can we do to actually retain these gains? And we are hoping that maybe the modeling data can look at what happens if you have 25% funding cut, if you have 50% cut. What will it actually mean to the programs, the implementation? Will we reverse all these gains we've had? We have 1.4 million people living with HIV in Kenya, about 1.2 million are on antiretroviral therapy, big prevention programs. What happens to them, and do we start seeing a reversal of what we have had? And so what we've focused on in terms of opportunities, thinking differently, is now looking at ourselves as organizations. The transitions now mean that we start taking up, we transition to the county governments to take up, we move from siloed interventions to integrated programs within the facilities so that government can continue even without external funding. And then data will always be king, might work. So we've done a lot of, in terms of electronic medical records, cloud-based paperless systems. So how we sustain that and then we use the data to inform the need for intervention is some of the priorities we're looking at. And we hope that they work. And so in summary, really, the lessons we've learned is that research policy practice cycle works every time and will continue to work, and it can be adapted for different programs. We're doing it right now for PrEP choice. So we're doing projects on PrEP implementation in the country. With the new technologies coming, we're preparing for how do we turn that from just the research itself to implementation. And sustained long-term funding is critical. And from the different sources, including and especially domestic funding. But if funding is to be cut, the things which must continue, for example, commodities and investing in the human resources for health, those are the two ingredients that we've seen. Without them, then the programs really suffer a lot. For researchers, there's need to tailor the research to real-world settings. So not just answering questions for the sake of research, but looking at what does it actually mean? Is this translatable? And the best way to do that is to work with the communities, to work with the implementers like ourselves, to work with the policymakers. Actually, from Health Systems Global, where we were last week, one of the key things is how do you make sure that research speaks to the policymakers and vice versa? And I think that's what was also being said this morning, where we put on that political hat, because sometimes we answer questions that are not needed or not wanted, is what we've been told many times. So looking at that. And finally, to be ready to adapt to the changing landscape. We have funding cuts, we have climate change, we have mental health, we have new emerging things. So how agile are we to adapt to the changes? Thank you very much.